Bismillahirrahmanirrahim. Assalamu alaikum warahmatullah. Today we are going to talk about the very basic and fundamental things of the X-rays. William Konrad Junction was a German physicist who became the first person to observe the X-rays, and it was a significant scientific advancement by making the invisible visible. Actually, he was doing a lab test in his lab, which was in Würzburg in Germany. What he was doing, that he wanted to see whether cathode rays pass through the glass. When he noticed during this test that there was a glow coming from a nearby chemically coated screen. And you know that when you are doing something and who did this and you don't know who did this, you say X did it, we don't know. In algebra, you used to do X plus this is equal to this. So X, what was X? We don't know X. So you are trying to find out the answer for what was X. So he didn't know what are these X-rays, these rays. So he dubbed it X-rays. He didn't know what it is. So that's why since then it is called X-rays. In Europe, in the beginning, some people, even in the books, they used to say Röntgen rays. But finally, X-rays was, which became very popular. So in the heart of the X-ray machine, there is an electrode pair, a cathode and anode. So you know that cathode is negative and anode is positive. So that is put inside a glass vacuum tube. The cathode, what is cathode? It's a heated filament. In old lamps, you can see there is a filament, a wire, a woven wire. So the machine passes current through the filament, heating it up. It is so much heated that it sputters electrons off the filament surface. And down there is positive charged anode, which attracts these electrons. The flat disk, which is made of tungsten, you will see in schematic drawing soon. So this is that tungsten plate, which is positive. Here is the cathode plate, or that filament, cathode filament, and the machine heats it up so much that the electrons beam come out and it hits the tungsten plate. And then what happens that there are electrons coming out from there. Actually, they are photons, and that is called X-ray beam. You can see from the machine here that X-rays are coming out. This is not a schematic drawing thing, it's not true, but the X-rays will hit the person, and on the screen, you will see his bones. So the voltage difference between the cathode and anode is extremely high, so that the electrons fly through the tube with a great force. And when a speeding electron collides with the tungsten atom, it knocks out an electron from one of the atom's lower orbits, the one which is having lower energy. So this poor guy will get out. And then an electron in the higher orbit, because the lower orbit is now empty, so it cannot be left empty. So one electron will come from the higher energy orbit, immediately it falls to the lower energy level. So what will happen to the extra energy that it was coming from? That will release its extra energy in the form of photon, and that is an X-ray photon. So this is the guy coming from the cathode, okay? It will hit the atom of the tungsten, and then let me show you by, I tried to make a motion in this picture. So let's go directly to that motion picture. So electron will hit, okay, the tungsten, And then this is the higher energy, this is the lower energy. The lower energy electron will go out. Now this higher energy electron will go down into the lower orbit energy. So let us say this was having 100 unit and this was having 50 units. So what will happen to the extra 50 units that it was having? It's just an example I'm telling you. So that extra energy will go out as photon of X-ray. Okay. So this is the basic theory. This is the very historic picture. This is the wife of Ranjan actually, and you can see her wedding ring also. This is the first X-ray ever done in the history of medicine, and you can see this is just a shadow. You cannot say what is what, but you can see that these are fingers, and probably on this side is thumb, and this is her fourth finger. It is kept in the museum. So Ranjan discovery was labeled as a medical miracle, and X-rays soon became an important diagnostic tool in medicine, allowing doctors to see inside the human body for the first time without surgery. In 1897, there was Balkan War, and this was first time used in military battlefield to find the broken bones and bullets inside the patient, actually inside the soldiers. And Nobel Prize was given to him in 1901, and he died in 1923. X-rays, remember, they are highly penetrating ionizing radiation. So this can be asked in exam. Bones absorb radiation more than the soft tissues, and that's why the soft tissues are less dense on an X-ray. You will see in a minute. X-rays from a source pass through the body and then onto the photographic cassette or detector. Areas where radiation is absorbed will show uh, denser than others. And since there are different structures in the body, so there will be a lighter shades of gray. Like this one, this is the ankle X-ray. You can see that the soft tissues are less dense than the bones. This is tibia, this is fibula, this is talus. But what we do in fluoroscopy, that if we want to see the digestive tract like esophagus, stomach, or small or large bowel, so we use a contrast agent which is called barium sulfate, and it is radio opaque. So when it is within the bowel or in the esophagus, that structure will look white like bones. Like this is the barium enema. You can see that the rectum, sigmoid, colon, and here the sigmoid, the cecum. So here it looks bright because of the barium. This is an X-ray machine in our hospital. Everywhere you can find. This is the source of the X-rays, and the patient stands here if we need chest X-ray. He's lying here if we need bones X-rays, and sometimes even chest X-rays, because we will see in a short while. Patient is standing here. This is the source of the X-rays. X-rays will hit his back, and this is the detector or cassette we used to put before, but these days now everything is digitalized. So we use this detector. And this is what is the result of these rays. The patient, as I said, if cannot stand, like it in ER, our patient is very sick. So the patient is lying down and this thing is mobile, it's movable, it can go here, there, it can come down. So the source of X-rays is this one. The rays are coming, and then on the side there is technologist who will press the button to take X-rays. These are our mobile machines. This handle, it can move 180 degrees. Like patient is in ICU, he cannot move. So you put the machine on the side of the bed, and you can move this. The technologist can see through this screen whether he's rightly doing things or not. He can see from here also. But finally, this is where he does the post processing and send it to the main computer so that the radiologist can do the reports. On your left is a normal chest X-ray, and this thing which you will see next year in detail. But what you can see that this dark shadow, the tube is trachea, the main bronchi. This is the cardiac shadow. These are the two hemidiaphragms, right and left. As you have the ribs, 12 on the right, 12 on the left. You have scapula, you have the clavicles on both sides and part of the sternum, but sternum you can see very well on the lateral view. On the right side of this patient, the lung is normal, and you can see the vessels and these markings that you see, we call it vascular markings or bronchovascular markings. You can see here, this is a vessel, this is a vessel. On the left side, you don't see any bronchovascular markings. And because there is too much air in the pleural space, the pleural cavity, and the lung is collapsed. Completely, the lung is collapsed, and there is mild shift of the mediastinum to the right side. So the patient urgently needs a chest tube to be put so that the air is gone and we can re-expand the collapsed lung. In this patient, you are having the left side, the costophrenic angle. Phrenic from diaphragm, costo from ribs. So costophrenic angles should be short. On the right side, it is not only that it is blunted, but there is too much white thing here, whitish. So this is pleural effusion. Now the pleural cavity is not having air, the pleural cavity is having fluid. So this is pleural effusion on the right side, okay? Again, this is trachea, and this is main left bronchus, main right bronchus, and this is the hilum, this is the hilum. So right pleural effusion. And you can see that the right diaphragm you cannot see because of the effusion. Here you can see the left hemidiaphragm. So how we assess the colon, sigmoid, and rectum? We introduce a tube into the rectum, and this tube is connected to a bag which contains the barium or water-soluble contrast medium. And when that is infused, that is, the bag is raised a little bit by pressure, we fill up. You can see the barium is going like this, and we fill up to the colon, and we will take images. So this is the rectum. Part of the rectum is not included in this picture. Sigmoid, okay. And then this is single contrast. Here is double contrast because we put a bit of the barium, and then we put air with a pump, small hand pump. We push little bit, bit by bit air, and then we move the patient, turn him round, turn him left, and so that it mix up. And you can see this is called double contrast, this is single contrast barium enema. This is a double contrast barium enema. On your left, you can see the cecum, the ascending colon, the hepatic flexure, the transverse colon, but the splenic flexure you cannot assess because it is all white. You cannot see the walls as good as here. So what we do is that we move the patient to the right side, put him on his right side, so that the barium flows into the transverse colon and into the cecum, and thus you can see that the splenic flexure is now clearly visible, and if there is any lesion, you can see it very nicely. Here you can see the sigmoid. It's a bit tortuous and you cannot assess nicely. So you move the patient a bit oblique and then you can see better. Here on your left, the patient is put in the left lateral decubitus position, and that's why you are having air fluid levels. So this is normal. And on your right side, this patient is having out pouches from the descending colon. This is called diverticulum, or more than one, so diverticuli. So these two are the diverticuli of the descending colon or distant or proximal sigmoid, sorry, distant distal colon or sigmoid. You can see normal colon. This wall is normal up to here. This is normal. But here it is irregular and you don't see this wall of the colon. So this is how the colon cancer appears. Another view, another patient also having, you can see the normal colon distally, and in between it has been eaten up, and you call it apple core sign. You see when you eat an apple, how it looks like. So this is called an apple core sign, and this is typical for colon cancer. Tiny densities when you see along the bowel loop, whether it is rectum, colon, or these are small ulcers. This patient is having Crohn's disease, so these are small ulceration that you can see in the rectum, upper part of the rectum. Now we come to the barium swallow. So we give contrast orally. The patient takes in a glass and we ask him to take a sip, keep it in mouth, and then we switch on the fluoroscopy machine, the X-ray machine, and we can see if he's swallowing. And then when he swallows, the technologists take the X-rays. This is the upper portion is the pharynx, and this is the cervical esophagus, the frontal view. This is the lateral view. This is the thoracic part of the esophagus, and this is the stomach. So this is the gastroesophageal junction. And again, the air fluid level within the stomach. So this is normal. Look at the normal caliber. And now if this patient has taken acid, he tried to commit suicide, and you can see that there is a very severe stricture of the thoracic esophagus. Look at the normal esophagus, okay, and look at the severe stricture of the esophagus due to acid. How we do the hysterosalpingogram? We put a neutral, a small tube into the lower portion, and then the gynecologists usually, or some of the female radiologists also, they inject about 5 to 7 cc of the contrast medium. This is the uterine cavity. We look as if there is any filling defect or tubes are blocked. This is the left fallopian tube. This is the fimbria of the fallopian tube. This is the right fallopian tube. This is the fimbra of the fallopian tube. So what is this all this? This is actually the fallopian tube is patent. So the contrast medium has gone into the peritoneal cavity. This contrast is in the peritoneal cavity. So means that the fallopian tube is patent bilaterally, and there is no dark shadow. It is all white. So there is no tumor like fibroid or anything else. Now, on your right side, this patient is having pathology. The right tube is opacified, but up to the fimbria, and there is no contrast in the peritoneal cavity. On the left side, the fallopian tube is opacified. This is the fimbria, but then there is contrast medium into the peritoneal cavity. So the left tube is patent and the right tube is blocked, unlike this normal case. Accidents happen, so patients are brought to the ER, and what you will see, I give you an example of the ankle, tibia, talus, and fibula. This is the lateral malleolus, and this is the medial malleolus. Now, this patient who had a trauma, so what you see, for sure, you see that there are fractures. The lateral malleolus is okay, but the medial malleolus is having a large fracture. Even there are more than one fragment, small fragments are there, and there is the tibio-talar joint space is also widened. So the ligaments means that the ligaments are also injured because there is widening of the space. And the fibula, epiphysis, long bone, you know that there is epiphysis, metaphysis, and diaphysis. So there is a big diaphyseal fracture, which is slightly displaced as well. So this is how the fracture will look like. In this case, these are the carpal bones. These are the metacarpals. The thumb is the first metacarpal is only partly included in the study. You see the second metacarpal, the third one, the fourth one, but the fifth metacarpal, what do you see? There is a big fracture, and this fracture is called Boxer's fracture. You can imagine, you cannot see me, but when you box somebody and the force will come this way, so the fracture will occur at this area. In this case, this is another patient with the other hand. So fifth metacarpal, fourth, third, second, and the first one. So the thumb is having problem. So where is the issue? Is it here? No, this is sesamoid bone, which is normal. Okay. So the problem is here. This area, this should have been here, aligned with the metacarpal. So here is the fracture, here is the fracture, and even here is the fracture. So fracture at the base of the first metacarpal. In this patient who is having breast cancer, so look at her left iliac bone. It's normal. This is air projecting here. This is also air. This is also air. This is, we have met a metal sheet to protect the ovaries. If you compare the left iliac bone with the right iliac bone, you can see that there is a large lytic lesion. Dark area is called lytic lesion, surrounded by sclerotic area. This is sclerotic zone. Whitish thing in the bone is called sclerotic, and dark is called lytic. Compare the right pubic bone with the left, superior pubic ramus, inferior pubic ramus, and this is the ischium. Look at the left side, inferior pubic ramus, ischium, inferior pubic ramus, and this is the ischium, and superior pubic ramus. Look at the left, it is gone. So it is dark, it is lytic lesion, osteolytic lesion. So this patient is having more than one lesion. When a bone is having more than one lesion, the first diagnosis, what we think is metastasis. There are other things also like multiple myeloma, but the first thing you think is metastasis. So this patient is having cancer, and since she was treated, so there is some sclerosis. This sclerosis is after treatment because mainly the lesion was lytic like this. This is a new lesion. How the bowel loops normally appear, you will see that the cecum Usually the cecum is having stool. In this case, the ascending colon is also having, you see this punctiform dirty image, this is stool and this is the cecum. So the first thing you see that the report distribution of bile cecum is in its place. It is not here. If it is here, means there may be volvulus, and patient will have other imaging features. All these two cases are normal images. Okay, so all the bowel loops are having small amount of air, which is normal. The caliber or the size of the bowel loop. So remember 3, 6, 9. 3 is 3 centimeter maximum size of small bowel, 6 centimeter maximum size of large bowel, and 9 centimeter maximum size of cecum. So you will study it next year in detail. But now I show you one of the obstructed bowel. You will see multiple air fluid levels, and you will see that there is distension of the bowel loops. Look at the extreme right one. The bowel loop is much more than 3 centimeter. Some people they take 2.5 centimeter, but just for the sake of easiness for students, we say 3, 6, 9. It depends on the presentation of the patient and condition of the patient. So anyhow, you can see here that this is about 4 centimeter size of the small bowel, and there are multiple air fluid levels, and there is nothing in the colon. The colon is collapsed. You can see here the rectum area, no air in the rectum. So this patient is having small bowel obstruction. I think this is my last image on the right. On your left side, you can see the diaphragms. Below the diaphragm on the left side is stomach. So there is air fluid level and some air in the bowel. Okay, so this is normal. But on your right side, below the diaphragms, there is so much air that even the diaphragm looks pushed up. This all is free air in the peritoneum. Okay, so this is called pneumoperitoneum or free air in the abdomen. And this patient had CA colon, which was perforated. Okay, so thank you very much. Raj.